Hello and welcome to Pulse, your weekly podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. I'm your host, Louise Shaper.
And I'm your co-host, George Margellis.
So, George, it's not like we're recording this podcast on a slow news week. But before we get to the news, well, how's life been treating you? What have you been up to lately?
It's been a hectic couple of weeks. Obviously, we know with all the announcements around health technology. I've had a bit of a personal issue with a friend of mine passing away, which has been quite tragic.
Oh, I'm so sorry.
Look, it's been hectic. I mean, lots happening. Health stands out still as something which really needs work to be done on it. And it sort of gets highlighted more when you realize the direct personal reflection on it. But moving forward, we really have an opportunity to leverage what we're doing to make things better for everyone.
I'm sorry about your personal tragedy as well. That's really sad.
What about you? What have you been up to for the last week? You've been fairly busy with some workshops and various things around the place?
Yeah. Actually, one of the coolest things I've done in the last fortnight is I'm part of a program called Seeker, where we basically teach clinicians, it's exclusively for clinicians, so any health professionals, how to be entrepreneurs and how to take their business idea from a concept to actually turning it into something real. And I was with a group of clinicians from Victoria the other day, and towards the end of the day, I was sitting with one guy and he was there's two of them, and they were showing me what they've built. And it was really impressive. They've built a medical scribe, but I was thinking, there's so many medical scribes. But anyway, they built one and it looked pretty good. It worked quite well. And they've actually coded it with MBS code. So it's actually quite unique. Anyway, and I was like, this is very interesting. Anyway, so we're having a chat. And then I said, well, how long have you been working on this? And he's like, probably about 4 weeks. And I was like, what? So I think he's a GP and the other guy's a radiation oncologist, and they've built a medical scribe with MBS billing codes attached to it, and they've done it in 4 weeks part-time. So I get to hang out with really smart, impressive people in that program. So that's been a highlight.
No, the Seeker program and the other program you're involved with, Amandeep, has been really fascinating. I mean, the clinicians coming on board and recognizing that it's not just a matter of building a better mousetrap, but understanding what's required around that mousetrap to make it successful. But it's something that is really relevant to them today, so they can use it straight away, and that builds that adoption. So looking forward to seeing the future releases from Seeker and the other programs.
Yeah, there's going to be some good ones, I think. There was another group that actually, as their case study that we were working through that day, chose a non-health tech-related problem to solve, which was people's problems in their marriages. So there was lots of laughter on the day and looking at the design thinking analysis applied to that problem. It was fun.
The health connotations of that are pretty dramatic as well. I mean, we've seen some fairly poor outcomes from marriage issues, so you have to be careful.
That is true. Well, let's get to our first hot topic, George. It's hard to go past the biggest global cyber outage the planet has seen. For Australians, it was late on our Friday afternoon. For the Northern Hemisphere, they awoke Friday to the news that the dreaded blue screen of death had grounded flights, delayed border crossings, left people unable to buy groceries, and made Mac users more smug than usual. Healthcare was not exempt, and reports quickly surfaced of impacts on health services in Canada, Australia, the UK, US and elsewhere. The impact was not evenly distributed, with some services not impacted at all, while others found critical systems offline, which in healthcare would count as a catastrophic major incident, with a full recovery that could take days. Literally, as I composed the script for today, I had a doctor message me to reschedule a meeting that we were going to have this morning because his hospital still had desktops out of action on the wards showing those blue screens, and he was having to deal with it. What are you hearing about the outage, George?
Well, it was interesting. My son was actually flying Friday afternoon from Sydney to the Gold Coast, and he rang me up from the airport saying it's a disaster, but fortunately his flights weren't too severely affected. I just think it's very ironic, isn't it, that a software company set up to protect us from internet outages, from cybersecurity issues, would be the cause of our biggest outage ever. And whether it was human error, whether it was programming. But I did read, as I was trawling the internet over the weekend looking for the relevant conspiracy theories driven out of this, there was a suggestion that a lot of cybersecurity software updates are actually AI enabled. These updates don't happen sporadically. They happen regularly during the day. They do multiple updates during the day. So whether there was an AI error or a human error, well, you have to find out. But I think it's interesting to discover that the implications of this are pretty significant and very significant to healthcare.
Oh my God. So the conspiracy theorists are thinking the machines might already be taking over. Oh, I thought we had more time. Damn it.
That's right, yeah. Classical photo of Arnold Schwarzenegger turned up yet again on one of those conspiracy theories.
Yeah. George, you have young clinicians in your family. How do you think, you've mentioned before, like whether their facilities might have not been impacted, but there are certainly others around the world that were and had to revert back to paper. And we've got a whole generation of people who don't know how to practice medicine on bits of paper.
Well, I mean, yeah, we've got a whole generation who probably don't even own a pen anymore. I mean, back when I used to graduate, yeah, you were given a Parker pen as a graduation present because that was going to be your tool of the trade. And I don't know whether my son actually has any pens anymore. So it'd be interesting to see. I don't know if I ever told you the story many years ago when I was doing work with HIMSS. I was doing the evaluation of one of the first HIMSS level 6 hospitals in Australia. The night beforehand, they had an outage caused by a storm. And the biggest challenge they had were there were no pens in the hospital. No one carries a pen in their pocket anymore. So even if you do go to paper, you need some way of actually writing on the paper. So it is challenging, but this really highlights the requirements for resilience. So for us to be thinking about plan B, plan C, and making sure we're prepared for these sort of outages. And maybe while we've moved everything to the cloud, maybe that old server under the desk has some value still. So we still need to think about what our architectures look like.
Well, in related news, if we stick to the cybersecurity stuff for the moment, in the US, and this just happened last week, a few days ago, a group of bipartisan senators introduced a bill that aims to boost cybersecurity in healthcare. It's called the Healthcare Cybersecurity Act, no surprises there. And that act would direct the Cybersecurity and Infrastructure Security Agency and the Health and Human Services to actually collaborate on improving cybersecurity across the whole health sector and to disseminate resources about cyber threat indicators and defence measures. And then in Australia, our Minister for Home Affairs, Claire O'Neill, announced the government is going to set up an information sharing and analysis centre for the health sector, which again would provide information to share information and share remedies on cyber threats. And then, of course, we've got poor old Medisecure, well, poor old 13 million Australians whose data was subject to a significant breach. We found out recently just under 13 million people's data is now on the dark web, and the company has gone bust. So these are ongoing issues across healthcare, and they're not going to be addressed anytime soon. What are your thoughts, George?
It is interesting in the United States that they have to legislate for government departments to collaborate. I mean, you think that would be a given, but hey, I guess that's a sign of the times that you have to actually have legislation to tell different parts of the government to work together to provide better outcomes for people. But the reality is cybersecurity is complex. I mean, it's not something you can just, as we saw, CrowdStrike, just having software in the background to solve the problem doesn't necessarily solve the problem. And it really goes to the fact that we need a cybersecurity literate workforce and population. And the fact that the endpoints touch pretty much every citizen in the country just makes it much more complicated. There is no simple answer, but it really does require us to think about the connotations of what's happening out there and make sure the training is there. We've all done it. I mean, I still get SMSs and there's that temptation to click on that link just in case it is really Nigerian prince sending me $50 billion, but it still hasn't occurred.
I'm sorry you don't have the money yet, George, but maybe if you just keep trying hard enough, you might get it. Over to our NHS update for the day. The UK Labor government is charging ahead with their plans to fix the NHS. There has been an AI in the NHS summit, and Lord Darzi has been appointed to lead an independent investigation into the NHS, as you rightly predicted in our last episode, George. You said there would be another review, and yes, there is one. Lord Darzi is well known globally as a leader in robotic surgery, and he actually last reviewed the NHS 16 years ago. Health Secretary Wes Streeting is promising action and a 10-year plan to radically reform the NHS after the review, and that's going to be published in September. So we will check back with the NHS then. But interestingly, last week, I don't know many Australians would have seen this, but the Tony Blair Institute ran its Future of Britain conference. It was a star-studded event, which included much reference to not just the NHS, but to life science and health research being a driver of not just improving health, but to driving economic growth too. And I'll put a link in the show notes because back in January this year, the Tony Blair Institute wrote a report called A New National Purpose Leading the Biotech Revolution. The report called for Britain to be a world leader in biotech, stating, and I quote, "The danger of falling behind is so great and the opportunities so exciting that we urge all political parties to make their response to it nothing short of creating a new national purpose." Very exciting and galvanising stuff. But in that report, in the not-so-fine print, they proposed setting up a company called the NHS Data Trust, which would be a company jointly owned by the NHS and private companies, effectively meaning that the data could be harvested and commercialised to benefit research and care. So we'll be keeping an eye on this space. But what do you think, George? Could the UK end up leading the way here?
Yes, the UK and the NHS reports. I mean, they do make for great reading, and I do have a collection of NHS reports on my hard drive, which, I've got to give them credit. They produce a great document. Unfortunately, they haven't really managed to implement some of those documents in the past. So hopefully Lord Darcy may have a little bit more influence than some of the many other very high-profile people they've had doing those reviews. You would have thought when they were part of the European Union, and there's some very large-scale European Union activities around biotech, that they would have collaborated with the countries 20 kilometres across the ocean, but they want to go standalone. Great luck with it. The reality is that this really is an international collaboration project. I mean, we saw during COVID that the international collaboration makes a difference, and I don't necessarily think individual countries trying to take leadership roles is necessarily the way to go. But however, any investment in biotech that provides opportunities for us to innovate in this space are welcome. So hopefully our colleagues over in the UK will generate some fascinating things. Hopefully they won't poach all our bright minds like they have in the past sometimes. So maybe an opportunity for Australia to link this into AUKUS, maybe AUKUS Biotech. We can have a look at the multiple collaborations. But I think, again, it just goes back, the fact that we fail to collaborate is systematic, not just in healthcare, but when we see some of the many other issues happening in the globe, the failure to collaborate is starting to swing the pendulum, swinging to less and less collaboration. And that to me is not a good state to be in.
Yeah, 100% agree with that one. Tony Blair Institute, obviously Tony Blair, not in government, probably has some sway over government, especially now, given that there's a Labor Party back. But it'll be interesting if they do proceed with some form of this NHS Data Trust company to look at the governance models around that and how data is protected, but also protected for commercial gain, which actually is not necessarily a bad thing, even though at the surface it can seem that way. But, I'd certainly tick a box saying that my data could be used to inform research purposes and help improve health outcomes at a population level. No, not everyone would. So I think we'll keep an eye on that and see if that eventuates and what the data governance models are going to be like.
Data governance in the European Union is probably amongst the strictest in the world. Again, it's that pendulum. How much data security do we need to enable us to take full leverage of it? My hope is that if they do make some money out of this, they can push it back into the NHS, because I'm a big fan of the NHS. I think the idea of free care at the point of care is critical to the social cohesion we have in our societies, and providing health equity to everyone via a free to deliver health service is critical for all of us.
And if we stay in that part of the globe for a little while, under something I like to think of as sharing is caring, I'm loving some recent news out of Ireland, where the Minister for Health, Stephen Donnelly, has published new legislation which, once enacted, will mean that pulse potties in Ireland will be able to access their own health information. Amazing. It also means that the health service executive in Ireland will be able to draw together health information from across care settings to create a source of truth for all patients. Now, Australia did this legislative dance some years ago, yay us, but yay Ireland for prioritising this now. I'd be keen to see more collaboration between Ireland and Australia, because I think we have a lot to share on the journey of modernising our national digital health system, as we're going to get into shortly with our guest today. What do you think about this one, George? Are you excited about this too?
So I was fortunate enough earlier this year to meet Stephen Donnelly when he was out here for St. Patrick's Day, when the Irish ran a very, very great St. Patrick's Day lunch in healthcare, followed by a number of Irish whiskies. Again, this model of sharing is caring. We know how important it is for that information to be available for those who it's relevant to. And the old patriarchal model of locking it behind closed doors only for clinicians to access for their own purposes is so 20th century, the 21st century. And we've had discussions with many of our colleagues around the world around this. It's great to see Ireland taking a forward step. I do note that later this week, I'm actually attending a Digital Ireland event in Sydney. So the Irish are Very progressive. They've done some amazing work. Again, collaborating with them. I enjoy collaborating over a Guinness with anyone. So happy to do it with all our Irish colleagues.
Brilliant. Yeah. I must say, whenever I spend a bit of time doing work with people in Ireland as well, and, Pulse IT has a very growing, prominent presence there. And I must say, when I'm hanging out with people in Ireland, even if I've met them like 10 seconds ago, they're just such lovely people. I feel like I've known them all my life, like we went to school together or something. I just love hanging out with the Irish, really smart people and just lovely people to spend time with. So yeah, let's look for more collaboration opportunities.
You've met my old friend Brian O'Connor, who's the head of the ECH Alliance. When Brian has a meeting, by the end of it, we're slightly tipsy, fed too much, but brains are just bursting with stuff happening. So they really are an amazing people. So I really look forward to working closer with them in the future. And hey, any Irish over listening to the Pulse podcast? Hello. G'day, I guess it was the right thing to say.
That's right. G'day. And I know that we do have some Irish listeners because the stats tell us that we do. And we've even got some Irish listeners, but they're based in Australia as well because those people have individually reached out to me. So yes, hello. We love you guys. Our last hot topic, George, I think, we have to talk about artificial intelligence, and let's not go down the path of the machines taking over just yet. But in a couple of AI-related stories, firstly, at home, friends of the pod, Keith McNeil, Enrico Cuera and Farah Maghrabi were amongst Australian digital health leaders who addressed the Senate Select Committee on Adopting AI, which was held in Canberra last week. Our friends, rightly, are calling for AI rules and regulation to ensure patient safety is paramount in the development and use of AI, and to enable its use broadly as the potential is huge and we're really on the verge of a revolution in personal medicine. And one example of a story that I really love this week, it was out of the US. This story caught my eye, where medical doctors are using AI to help patients get their treatments covered by health insurers. So it's no surprise that the insurance sector in the US is using AI to justify denial of treatment coverage. But some doctors are using chatbots to synthesize research and make the case for funding back to insurers, where increasingly prior authorization is required by the insurer. George, aside from being grateful that we're not subject to the substandard US healthcare system, I do love this idea of doctors using AI to benefit their patients in this way, and great to have really strong representation to the Australian Senate Select Committee. What are your thoughts on this one?
First of all, it's great the Senate Select Committee picked those three individuals in particular who are local Australian AI experts and to understand the context of what's happening with AI in healthcare. And whilst I've sometimes been a little bit negative about the hype around AI, I do believe it is a very significant advance and it will make a huge difference in the delivery of healthcare going forward. So kudos to those three. Again, it comes that challenge of, is regulation enough? Do we need cultural change around here as well? And that's part of the challenge they're going to face forward. To our US colleagues, a number of US doctors I know, their biggest burden, their biggest challenge, the thing that keeps them awake at night more than anything else is the insurance companies. The US model of these multi-trillion-dollar insurance companies controlling who gets care and how care is delivered and determining what the metrics are around care is really scary. And whenever we've had that suggestion of that sort of system arising in Australia, I've been pretty active with most of my medical colleagues to prevent it happening because we've seen the connotations of it. So if we can use AI to beat the insurers, kudos to them, and I really give them great credit. The reality is I'm sure the insurers are spending millions, if not billions of dollars in the back end building their AI tools to battle the doctors. So again, this model of collaboration, rather than insurers and providers collaborating for patient outcomes, we have lack of collaboration causing poor patient outcomes. We need to really think about, is healthcare a social good that goes beyond some of these commercial models? But that's by the old socialist in me beating my drum, I guess.
Oh, well, you're amongst good company here. You're not going to get any argument from me on that one. And actually, I think for our next episode coming up as well, we're going to do a bit more of a deeper dive into this with we won't announce it now, but with our wonderful guest who we've lined up to talk to us on the issue of patient engagement and access to their own health records and contribution to their own health records out of the US. So we'll go into a deeper dive on that in our next episode. So I think it's time for a break, George. And afterwards, we'll be back with our special guest of Pulse, Peter O'Halloran, Chief Digital Officer at the Australian Digital Health Agency. In Canberra last week, the digital health community descended on our nation's capital for a briefing by the Australian Digital Health Agency. Now, this was a pretty important briefing, and so we're rapt to be able to bring the key components of that briefing to you today. Joining us in the Pulse Pod studio is Peter O'Halloran, Chief Digital Officer at the agency. When on stage in Canberra, Peter and his colleagues outlined what is a fundamental shift in the way the Australian digital health system works and how health information will be shared in the future. Now, we're talking a vision of a health information exchange, or HIE, that will enable better, fasting sharing of information across all care settings. And that's really important. So we're not talking just hospitals here, but general practice, aged care, pharmacy, allied health, the list goes on. It will also involve the modernisation of our My Health record system. Peter, welcome to Pulse.
Hi, Louise. Lovely to be here with you and George today.
Great having you on board with us today, Peter.
Peter, let's give our listeners a bit of a background first. So can you please briefly explain what the My Health Record System Modernisation Program is all about? So I understand that you plan on moving a little bit of a creaky 12-year-old system from a clinical document system to a FHIR-enabled system. And who should care about this? What does it mean in practice? How is it going to be better?
Look, I think it's something that all of us should care about. From a technical point of view, it's about modernising all of those old age pieces of IT infrastructure that might have been cutting edge 10, 15 years ago, but don't meet our needs today. And that probably is why we all need to care about it, because fundamentally it's about ensuring that My Health Record has information in a way that can be used by everyone who needs it, that they can access it in their own clinical systems or in their own palm of their hand if they're a consumer, in a way that meets their needs. So we're doing things such as moving from a monolithic tech stack to something that's composed of microservices so that we have a single function that does authentication or authorization, and we can then use that like the building blocks as foundations for My Health Record or a health information exchange or something else for years to come. And it's about moving away from all that data that's locked up in those sort of CDA PDFs into atomic data so that a clinician can sit there and simply graph the results on their existing clinical system now in a way that helps them assist that clinical workflow, not hindering it. And it's about making sure the consumer's at the heart of everything we do. The consumer should have the power over where and how their information flows, but also about understanding their health conditions and actually being part of those conversations. And that's what the My Health Record modernisation is all about.
Now, obviously, the My Health Record is going to be part of one of those national repositories that will be part of the HIE. But health information exchanges have been a term that have been bandied around for quite a while. Do you have a better definition of what it is? And are there any examples of it in place currently in the world where they use this sort of system?
There are so many countries who have got health information exchanges out there at the moment, and we've looked at all the big ones like the UK and US and Canada and a whole lot of the European nations, and increasingly a lot in the Middle East where they're really leapfrogging a lot of us. I suppose I see health information exchange is fundamentally the way I'd define it about what the outcome is that it provides for all of us, which is for the consumer and with their permissions, the clinician, they've got access to the right information and all that information about that patient at the right time to enable care to occur. So it's about moving data around for everything from appointments, allergies, medications, dispense records, any messaging that happens between different healthcare services and those individual clinicians in them, putting the consumer in the middle of that, letting them see the data that's flowing, and making sure that the clinician doesn't have to stop and think, oh, what's happening with this data? I'll go and log onto one portal or another system or a third one or a fourth one or a fifth one. Log into their own system once, have all the data source there that pulls it in from wherever it might be stored, whether that's in My Health Record, whether that's in their own system, or whether that's sort of in a different practice down the street or a radiology provider on the other side of the country. That's what it's about, getting that information to everyone in real time at the time they need it.
Me personally, Peter, I'm really looking forward to this. My mum is dealing with the healthcare system at the moment, and I'm on the other side of the country. And I can't tell you how long I've been spending on phone calls to radiology providers, hospitals, getting bounced around just to get a copy of her x-ray. So far, I have not succeeded, but I'm going to keep trying. So I love this idea with the health information exchange really breaking down those silos. And in your briefing, you mentioned that HIE would be able to facilitate a requesting function. So a healthcare provider can use their own clinical system, but actually through their system go and find extra information that they might need that's not in their own records or necessarily in the My Health record. Without getting too technical, how does this work?
It's one of those core functions I talked about at the beginning where we have those foundation pieces we're putting in place. One of those foundation pieces is a discovery service, or as some of us call it, a record locator service. In essence, what we do is we centrally index all the information stored in each clinical system. At the heart of the HIE, we keep a little tiny stub record that says GP practice A or B or community pharmacy C holds information about Peter, and here's his identifiers. When a GP then wants to log into their system, or anyone else in the care community, they log onto their system can query that HIE central index in real time and show them all this information is here, and we'll start retrieving that for them on the spot from the source system where it's been stored. So obviously it's always good if you can retrieve the data ahead of time, because it just means you load the screen, it's there instantaneously. And there are some systems on the market that do that today for how they query My Health Record. What we're looking at is, however, making sure that the function is there, that within a minute or two, all that information is displayed for the clinician in their own system. And the heart of all of that really is having that central index, that sort of master index in the middle, in the core, that says these are the systems that hold information about a consumer. What that means is it's then fairly quick and easy for the system to then go and retrieve data just from those individual ones that hold data, not going out and querying every single clinical system in Australia every time someone interacts with a patient.
So one of the challenges we obviously face here in Australia is that we've had health technology systems in place for many years. So general practice has been computerised, some 30 years now. What does this mean from the old software vendors' perspective? Do they need to do major modifications? Do we need to re-architect all our clinical systems? Or is there a way of us cobbling this all together in such a way we can do this in the short term?
Look, it's a bit of both, to be honest. And as you mentioned, we have had the digitisation of these systems in general practice, say, for 30 years. And the challenge we have is the architecture for some of these systems has not changed a great deal in that time. There will have to be a lot of modernisation of these systems by the software vendors. We do expect that they will, over time, have to re-architect their core platforms. And talking to all those software vendors, and this is sort of one of the great things about Sparked, the Fire Accelerator, is they are actually already starting to do this and thinking about this. Now, the challenge is that timeline too long? Well, of course, they're going to do it over a number of years because that's how you fit the investment cycle in. I, of course, am the complete opposite and want it all done tomorrow, which is completely unreasonable as well. And so it's really about that, how long it takes them to come on that journey. But those vendors already are modernising them. And then the next thing, once those systems are modernised, is how do we ensure that the customers of those software vendors, so the individual allied health professionals or community pharmacies or general practices or whatever other group we're talking about, they need to move to those more modernised systems. And those systems have to be hosted professionally. We need to move away from what I still see every day of sort of the PCs on the receptionist's desk, or if you're lucky, maybe it's out in the lunchroom in the corner, sort of whirring away on top of the fridge. We need to move to them being professionally hosted, whether that's in the cloud or whether that's in a data centre. That part doesn't matter so much, but we need to ensure that those systems are always available, always on, but also most importantly, that the data is always protected, because that's my number one fear that I think about at night is I can just see it now in a whole lot of these practices. You've got a whole lot of unencrypted patient data just sitting there waiting for some opportunistic thief to come in looking for something else, who walks out with the PC that has all the data. And I think that's not fair to any of our consumers, and it's not what any of us want. So yes, it will be a change to software, but the good news is the vendors are already doing that. The other part I would say is we don't need to wait for the HIE to start getting some of these benefits. We have My Health Record. It has some great functions. It has some great features. It has a great legislative background and process. Yes, it's a bit clunky. Yes, it's not meeting all of our needs. And yes, at times we've all sat there and cursed at it quite profusely. And I'm not the only one who's done that, I'm sure. But it does still help us move some information around now. And so the other thing I'd say is we want those practices, while their software vendors are upgrading systems, to keep using what we have, because what we have now will still help information flow. It's not as good as it should be and as it will be with an HIE, but it will still move that information around for us now.
Brilliant. And I love the example of the server or computer sitting on top of the fridge. I don't know if you've actually seen that, but it was a few years ago now. I was having a mole check, and anyway, they said, "Oh, you need to come back in 6 months because there's a mole we're particularly concerned about." So I made an appointment, came back in 6 months' time, and I saw the same doctor, but it was in a different consulting room. But you don't even think about it. Who cares? Anyway, it was a massive problem because when they said, "Oh no, it looks fine." I said, "No, but how does it compare with the picture that you took last time?" And it took me ages of really really had to probe them a lot before they told me the truth. They didn't have a server at all. So my first photo was stored on a local computer in one room, and now I was in another room, so there was no way for them to compare. And anyway, I was like, okay, I really need to talk to you about digital systems here. So it's only a small example, but the healthcare system is littered with these examples of massive disconnects by having all of this information in different silos. So anything that we can do to actually improve that for the patient, the consumer, so much better. And Peter, a relation to that is that healthcare identifier service. So I know when that was launched by NETA back in the day, the idea was there would be one number that would identify a unique number for a patient, a unique number for a practice, and a unique number for a healthcare professional. But my understanding is, despite the brilliance of that idea and its widespread implementation, it's not everywhere yet. So with the HIE, does that mean that the healthcare identifier service, does that need to change, or does it just mean it gets further widely adopted?
This is my number one bugbear, and I look back on my career so far in health IT, which has been a couple of years now. I'm not going to think about how many grey hairs I didn't have when I started in this area. We're 10, 15 years on from the healthcare identifier service being set up and run and all the work that was done. It's still not routinely used. So I've gone to my pathology provider. Not only do they not have my IHI, they refuse to put it in my record. And so I've now found a new pathology provider. And the challenge we have is we have a system, it actually works and it works really well. And it has unique identifiers for consumers and for staff members and for organisations. But many of our providers and many of the people who are involved in the system just simply don't use those identifiers. And so we actually, in the last few weeks, released the HI roadmap, which actually sets out what do we need to do to take it from what is a good technical solution to something that actually changes clinical care. And so what we're now doing is working with all those health services to actually start ensuring that the healthcare identifiers are being used every day in every record, in every piece of information transfer, whether that's electronic or a piece of paper that's sort of being printed out and handed to a consumer as they move from one provider to another. The use of those identifiers is one of the biggest single benefits that we will gain from all of these things. Where actually, if you talk to people, say in some of the other countries, let's talk about the US, for example, they've got the 21st Century Cures Act, which, if I believe many people, is the best thing since sliced bread and will resolve in sort of no poverty and world peace. If you talk to individual clinicians in America, they go, look, it's great. The problem is, though, because we can't legally have a single unique healthcare identifier for our consumers across the country, we have massive problems where the records are duplicated. And so some of the estimates are up to 20% of data moving through TEFCA through the QHINs now is a duplicate. But also the clinicians aren't always assured of the data integrity to actually make sure that it hasn't been two records that have been merged because, well, it looked like it was roughly the same name, the same date of birth, came from the same city. Well, it must be the same patient, so we'll merge them. It isn't. And so the use of those identifiers is a key thing. And if you look at the Quality and Safety Commission's standards for healthcare providers, one of the things they have to do is actually use healthcare identifiers and use the national healthcare identifiers. Now, unfortunately, I would say the bulk of hospitals in Australia do not use them for every patient today. And so they are actually not complying fully with that requirement from the Quality and Safety Commission. Up until now, that's sort of been tolerated because the agency would grant them an exemption from that requirement. We've taken a new approach in the last 12 months, and just over 12 months ago, we wrote to the hospitals that still had these exemptions saying, we won't continue to grant the exemptions. You actually need to make real progress. And we've been working with them since then. We now have a whole range of sort of migration plans for these health services in operation. We have some hospitals in the last few weeks that have actually gone and fully implemented their healthcare identifiers across their services now. So what you'll see in the next 12 months, certainly in, say, that the hospital space, which is one of the areas where it was most problematic, they will start using them and using them fully. Once that's happening, we look at the work that's going on with, say, Sparked and e-requesting for pathology and diagnostic imaging. A core part of that data set is the healthcare identifier must be there, which then looks at how we close that loop with pathology and diagnostic imaging. If you're then sitting in aged care or in a GP setting and so forth, suddenly that healthcare identifier is actually useful because it lets you see information about your patient from those providers that previously didn't link it together. And so the healthcare identifiers are the core to how we'll make all this work. Yes, we will get everyone to start using them, and there's a lot of progress going on, but it's also the most infuriating thing where I look back and say 10 years ago, if we'd all actually done then what we probably should have, we'd be a lot further down this path already.
That's very interesting, actually, because I remember, I think it was about 2010 when Mukesh Agarwal was running around the country trying to get that healthcare identifiers. And those use cases that he gave are exactly what you're talking about now. So they talk about it taking 17 years in medicine for ideas to come through. We're 14, so we're doing a bit better. I think it's a great thing. I think the most exciting thing you said at that presentation was that this is not an ICT project, it's a clinical transformation project. And I think the core of this is that the way we deliver healthcare hasn't used data as effectively in the past. A, because the data wasn't available, and B, realistically, clinicians like myself and Louise and others were never really trained to think about data flows as part of our delivery of service. We thought about patients in front of us, whatever information we capture then and there, we use that, and it was a very piecemeal thing. So this idea of data being a central tool throughout the entire clinical journey is really exciting. What are we doing to get the clinicians trained in that model? Because I did med school many, many years ago. My son did it a lot later than that. The models of clinical care really haven't been transformed to take into account data. And as a clinician, I was a fairly technical clinician, so I love data, but most of my peers just saw it as, something they had to do to fill in the record. How do we get clinicians to think about this data journey as their core part of their way they deliver high quality care?
I think it is, George, about changing the mindset. It's about changing how people think about how that clinical workflow operates. It's about changing how people are trained. But before we can expect all the universities across the country to change how they are teaching our future clinicians, we also need to prove to them that actually it is safe to change how they do that training. And the challenge we've had to date is it is gobsmacking and terrifying what we impose on our clinicians today, where you're sort of expected to make decisions that are life and death, often with imperfect information is probably the nicest way I could describe it. It's probably far worse things we could think about. And the fact that we haven't to this point had that rich set of data flowing for a clinician to use, I think is just terrifying. So I think before we can expect the universities to change how they're training, and we've seen some evolution of that training already, where often now the use of an electronic medical record system or different ways of documenting that aren't on paper are routinely being taught in universities across the country. And a slightly terrifying thing in a former career a few years ago, when we implemented an electronic medical record system in the hospital system I was part of at the time, we actually had to do specific training for some of the newer graduates about how to document on paper for downtime procedures, because they didn't know how to document on a paper medication chart, which in one way is great because you go, okay, so clearly they're learning about digital means now in their courses, but equally terrifying of you need those backup and contingency arrangements because no system is ever perfect. So I think to get to that change as a sector and as a community, we need to prove to the universities that actually we now have a data-rich environment where the data can be trusted, where it can be accessible, where it can be protected and be secure. As they see that evolution, they will continue to change the way they're training. And look, we're already working with the Digital Health CRC about some of these things. The Digital Health CRC have formed a new group recently across sort of 30 plus universities in Australia. Like, there is change coming and we're seeing it. But I think it's also at this point in time, we actually have to give those academics the confidence that as a system, we've actually got this now, and we're actually putting these data sources in place so they can train our clinicians of the future. What we then do to train people who are still practicing, who have gone through in different ways, I think is a much bigger challenge. And that's where we need to work with the colleges to really work through what is appropriate and safe in the clinical practice for that particular group, to work out what works for them and what doesn't, because it isn't a one-size-fits-all approach and never should be.
Peter, at the briefing, you used a scenario of someone experiencing chest pain at home. They call a phone triage service like Health Direct for advice. Health Direct says call 000. With an HIE in place, does that mean that, when the AMBOs come to my house, they're going to have access to my recent tests? Obviously not right now, not tomorrow, but is the idea that the ambulance officers, they would have access to the data? Could it incorporate data from the ECG on my Apple Watch as I'm being raced there? Will the hospital know what to expect before I arrive? What's the idea vision in that sort of scenario?
Today already, paramedics could have access to my health record if they want to. The legislative basis is there. The technical impediments have been largely resolved. That can be done today, but is not being done today. And so that's one thing we're working on right now, because I'm too impatient. We can't wait for an HIE to arrive to solve all of our problems. So we're already doing work, and we've done some design work in the last year or two to look at what would it take to make my health record be useful for a paramedic. And that's all about having a revised view that gives them the core information they need very quickly. They might have 10 seconds to look at, they can have a quick look, get what they need and move on with the job. So we're already focusing on doing that right now. of how can we actually have a new view for My Health Record to make it easier for those paramedics and also for the O call takers to actually have access to that data. That's the first part of it. That, I would hope, within 5 years, we will see every paramedic crew in Australia, if it suits the circumstances, can access a consumer's My Health Record. And look, there are going to be some cases where it's not appropriate or they don't have time or it's just literally they roll up at a motor vehicle accident and, to be honest, they're generally, My Health Record is not the first thing going to be on their mind. But for all those jobs, if that works from a clinical workflow, we want them to have access to that system. And so that's I want to do over the next couple of years is work on how do we get that data out to them. With a health information exchange, then we really turbocharge that. So we can actually pull through the data that might be on a wearable that you've got. So you've got an Apple Watch on your wrist. How can that data be, if you want to, shared through My Health Record and through an HIE in real time? And we're already doing work on that right now, and we're going to market in the next couple of months for My Health Record on Fire repository, which sounds suitably unexciting, but fundamentally what it lets us do is start taking atomic data from consumers, from clinicians, from regulated medical devices to actually be shared through the My Health Record system. Once again, that actually won't require the HIE. That's stuff we're working on right now that we have funding for right now. And my service designers, I think, are tearing their hair out, as I keep saying, so how soon before I can actually upload my data? How will it work? What will I see? That's what we're focusing on right now. So that will absolutely be there. The challenge then is how do we give those paramedics and the consumer, but also the staff in emergency when you get to the emergency department, access to the complete set of information. And that's where the HIE will really come into its own. But I'd also see the scenario in the future being, as the paramedics are wheeling you through the door of the emergency department, and I hope this is just a scenario and doesn't ever happen to you, that as you're getting wheeled through those doors, the data is being transferred in real time as well. So that whatever system the paramedics are using, that data is being transferred in real time through the national HIE to made available to those clinicians. So as the paramedics are doing handover to the triage nurses in ED, the data is flowing electronically at the same time as they're doing their verbal handover, so that the clinicians in the hospital can keep treating you, having that complete set of data that's been collected while you've been in the paramedic's care. That's where we want the HIE vision to go, so that as you move around the system, your data is just there and is available to those clinicians to treat you with the best possible information.
Obviously, this requires innovations in both clinical models, innovations in some of the technologies, innovations in just the way we think about how we deliver care. And it also drives things like multidisciplinary teams, because as we share that information with more people, we have the opportunity to leverage a whole different set of skills. I mean, shifting the focus over to where I'm doing a lot of work at the moment in aged care, we're about to go through that clinical transformation journey in aged care. So I guess it's really important that sectors that are new to the game jump on this early. Advice to startups now, what sort of advice would you give them to build tools that would work with this HIE that may enable them to add value to existing clinical systems?
Look, my first piece of advice is don't give up, just wait a little while. There is change actually coming. And so some of the things we're actually doing for those startups right now is to try and modernise and streamline how you connect to My Health Record, because at the moment that is a torturous 12 plus month long journey. And I've been on both sides of the fence trying to connect to it and also now administering the process. And so I've set my team the ridiculous target, and we're already starting to move towards it, of ensuring connections can be done in under a month. Because startups don't have 12, 15, 18, 24 months to go through a government bureaucratic process. So we're streamlining that process right now, and we went live a week or two ago with digitised forms, which sounds very unexciting and, to be honest, is really unexciting, except that it helps the data start flowing to those people in the pipeline to get people connected much faster. It means as those forms are filled out, we can do our job quicker. We can then work with our partners. We're rewriting all the documentation to mean that hopefully you and I can understand it, George, because quite frankly, I thought I knew something about IT. I look at these documents and lose hope. We're fixing that. So for the startups, I'd say think about the patient always at the centre. If we think about it from a patient perspective, we get that complete journey. We get the idea of having that whole full picture about that consumer at the centre. That also then means, hopefully, as they're then providing the innovation for clinicians, that they're also thinking about how's the clinician going to interact with that consumer? How do we ensure the clinician has the information in the right way, in the right place, with the right bit of great decision support or the great new machine that goes ping that gives them new sets of data or helps with the diagnoses? And if I was a startup, one, don't abandon hope. Two, recognise that if you're actually doing these things, use international standards, because it will help you plug into both our future infrastructure but also those more broadly. And three is don't forget about the consumers and the clinicians. If you put them at the heart, everything else will flow.
I think that's great advice for any startups listening. Take that advice on board.
Absolutely. And I was literally in a meeting yesterday, Peter, where I said, oh, we'll be able to connect to the My Health record soon. And the founder went, oh, like in a couple of months? And I did have to laugh and say, well, it's going to take a little bit longer than that. But I said, but it actually will get a shorter time frame. But I was like, yeah, encouraging them to start sooner than later. So thank you for that. Look, this is so exciting, Peter. What sort of timeframes are we looking at?
A lot of this work has already started, to be honest. So the work around getting the health identifiers roadmap in place has been going on over the last year or so. In the last few weeks, we've had a number of hospitals who have actually now removed the need to have an exemption because they're using the identifiers on all documents, in all clinical handovers, in all those transfers of care. For improvements to connection to My Health record, we've already decreased the time by at least 2 months over the last few months. So we're already making progress every single day. If you look at our annual procurement plan on AusTender, what we'll also show you is we are going out to market a number of times in the next 11 months during this financial year to purchase and implement new technologies. So a Firebase repository for My Health record will be in place in less than 12 months. The timelines are now. Some of these things will take us 5 years to do or 7 years to do. The majority of those foundation pieces and all the key critical pieces we need to get a lot of those improvements will be in place in the next 2 or 3 years. But we're not going to say wait 2 or 3 years. You will see every month or two, another piece will drop. There'll be another piece of the puzzle that will be done that will help to make these things move forward. And that's the key thing, I think. Some people have said, oh, look, there's hundreds of items to do and you need to focus on one or two. Yes, there are hundreds of items, but they're also shared between everyone in the sector and not everyone has to do all of them. And so I think we're seeing those pieces being done by the individuals who need to today. And that's a good thing to see. And Sparked is probably the other one of those I'd say is, yes, it's developing implementation guides for fire. It is actually having what is a core data set to let us interoperate and share that information across the country. And it's being led and designed by clinicians and by software vendors who are writing software today that is used across our care settings today. So the future is now. The timeframes, to be honest, for a lot of these improvements, I'd say within 3 years, you'll see them. But every month between now and then, you'll see further incremental improvements.
That's great news. So we will be seeing change happening over the time. So as you know, Pulse listeners are the smartest, most passionate, most compassionate people out there. We love health IT. We've been doing this for all our lives. What can they do to prepare for this and help? We really want this to work. How can we help you guys to make this happen?
Look, there's a couple of things that I'd say. One is making sure that whatever those pieces are in those areas that those people work in that need to be done to enable this future to occur, they should be doing them now. Do not wait for everything else to get to you. Start making those changes now, whether that's looking at what your system is, how you host it. Do you actually have the national healthcare identifiers in your data system? If you're a software developer, every single time you're developing something, do you have the consumer and the clinician at the heart of what you're thinking about? Are you using those standards? Are you engaged with the Spark community as we develop all these fire implementation guides? If you're a health service administrator, it's about recognizing that the models of care that will be delivered will change because of this and start thinking about that now. Because the other thing we need to think about is we don't want any perverse incentives that will stop this transition of moving to a data-rich environment where consumers and clinicians actually have the data they need in real time. Because there's a particular incentive that a particular group says, well, we're not going to share data because it might impact our business model or something else. Let's flag those issues up front now and tackle them. And look, that's part of the challenge for my colleagues in the Department of Health and Aged Care. How do they look at these legislative and policy levers to make sure that it supports the vision that we all have, which is to enable better care in a more timely manner?
I love it. And Peter, last question. We have listeners in over 10 countries already. So there'll be people not just from Australia listening to this interview. When the journey that we're on, is this going to make us even more world-class in terms of how we manage health information across the entire sector?
Absolutely. And if I talk to my colleagues internationally literally every week, and it's one of the fun parts of my job is I get to find lots of really exciting people doing cool things overseas as well and talk to them. They already look at some of the things we have in Australia now as groundbreaking. And what I want to get to in a position in the future is we have better care in a more timely manner that's more equitable for all Australians and that the world actually sees that. So I think absolutely when we get this right, and it won't be an if, it'll be a when, we don't have a choice. To be completely frank, I'm going to need the healthcare a bit more than I do now. As I get older, we're all going to need better care, and as will our families. We all need this. And so across the sector, I'd say there is really an immense enthusiasm to get it right and to do it now. we will be world leading. We will have centres of innovation across the country that are really showing us how we can do this to help improve health outcomes for all. Will we be the best in the world? Probably not just yet. But over time, absolutely we will. And my sincere hope is, as we move to this data-rich environment that George described it as, and it absolutely is, that will require and encourage further and further innovation that really will drive us to be the best in the world. So I would encourage your listeners at other 10 countries to look at Australia and become involved in what we're doing as well.
George is always promoting us as a destination for people to quit their jobs at home and come over here.
Absolutely. But it's interesting because, you look at things like the Commonwealth Fund reports. We are up there as one of the best healthcare providers, but this really does give us an opportunity to make that leap to the next stage. And whilst Australia has one of the best longevities in the world, we do have that challenge that our health span isn't quite as long as our lifespan. So using these sort of tools to improve our health span so that we actually are long living and healthy living is a great initiative. So first of all, congratulations. I think it's a great initiative. Understandably, it's taken us a while to get here because this is not an overnight success type project. But I think the vision is fantastic, and I'm really looking forward to having data flowing seamlessly as I'm rolled into a hospital, touch wood, sometime in the future. And I'll just say, my mate Pete did this. It's all working well.
I think, George, it'll be not just your mate Pete, it'll be every single person you know in the sector. And that's the good thing, is it is actually all of us doing it together, which is great.
But I will drop your name to make sure I get a little bit of extra service.
Oh, thank you, Peter. Well done. Echo George's congratulations for you, the whole team at the agency, the Sparked people, every single person that's behind this. And yeah, we look forward to helping to grow that community of people contributing to get this reality where our data actually follows us around in a secure way so that we don't have to waste time and effort and have poor health outcomes, which is actually a result of what happens when our data doesn't flow and sit with us. So thank you so much for all your efforts, Peter, and thanks so much for joining us in the Pulse Pod studio today.
Thank you, Louise. Thank you, George. As always, it's lovely to talk with you.
Now it's time for an update from our correspondent, Kate McDonald from the Pulse IT News Desk. Hello, Kate. So you survived chilly Canberra. I wonder if that Tasmanian cold that you live in has trained you to not even notice how cold our nation's capital is.
It was a beautiful day. It was 12 degrees. It was the first time I've ever been in Canberra, and I didn't feel the cold at all. I'm originally from New Zealand, from the South Island in New Zealand, and we know cold down there. So Canberra was glorious.
Oh, wonderful. Okay, well, tell us all the news updates that you've got from us.
A lot happening. The last week was pretty much dominated by what came out of that meeting in Canberra, the new plans for health information exchange for Australia that Peter just spoke about. We covered it pretty extensively in Pulse IT, so if you want to know more, then go to our website and there's lots of stories there. We did some polling over the weekend to see what our readers thought about the plans, and 80% of our readers said that they supported the plans. We got some comments as well. One was in favour, and this was a clinician who is an anaesthetist who said sharing of data is what patients expect. And they still run into a problem that patients are surprised they get asked questions about their health background that the patient's already told the hospital and the surgeon, but they get asked yet again. Another clinician, though, was firmly against the idea of health information sharing, warning that databases are always hacked. We've seen that recently. They also said that as a clinician, data overload will not help them. Health information exchange, is too much data. And I think that that's a really relevant point. But the clinician also said, importantly for them, that except for allergies, there are almost no clinical situations in which instant data availability or instant history availability will change the course of that patient's recovery. I don't think that this clinician's had a good experience with health IT. I think, George, you can probably comment on as a doctor. Would you agree with that comment?
Look, there is some credibility to it. In some cases, you basically need to make decisions right on the spot. But when you look at people with chronic diseases, when you look at people in this sector that I'm working now with aging, where you need to really understand more about it, I think that's probably overstated. The question of data overload is important. Gigabytes of information aren't necessary. So part of the challenge we face is how do we document in a world where we have shared information systems? Do we document the same way we've always documented?
The other thing I think that clinician, and I feel really bad that, they're a reader of Pulse IT, right? So they haven't opted out. This is good. They're very engaged and active in the community. But I completely get that they've probably, and because a lot of clinicians have, let's face it, have had a really shit experience dealing with IT systems that aren't really fit for purpose for them. And so if this particular person's default is to think that, oh, great, just what I need, data overload, that actually points to a bad experience or bad experiences with how systems are designed. I think we as an industry need to do a lot better of designing systems so that with the health information exchange, we need beautiful design dashboards that I can customize because I'm an allied health professional and this is the type of data that I need to see, or I'm an emergency physician, this is the type of data that I need to see on people in this way. And our needs are all very different and customizable. That's easy stuff to solve though. So I would hope that those things are taken into account and prioritized to make sure that what we're building with these health information exchanges isn't just an infrastructure layer that enables it to happen and we end up with data overload, because that's not going to help anybody.
It's going to be an ongoing topic. We'll be following the building of the HIE for foreseeable future. At the presentation, it sounded great. It sounded exactly what the Australian Digital Health Agency has been talking about for 10 or 15 years of getting connected care going. Finally, we might be able to, but whether clinicians are interested or not is obviously another matter. So we'll keep following that story, definitely. We're also following this week the CrowdStrike incident. We don't actually have much information on whether it affected hospitals. It obviously did affect some, mainly we think probably scheduling systems, but hospitals have contingencies and workarounds for these sorts of problems. It probably would have affected GPs more. We'll look into that. And also, actually, Dr. Glaucomflecken, who I'm sure you guys know, who is a very, very funny comedian and ophthalmologist, he did a really great sketch showing what, let's say, mature doctors would do if their systems went down. And he wrote his patient notes by hand, showed it to the camera, and obviously no one can decipher his handwriting, which is an age-old problem. And the other stories we're covering, the MediSecure breach, which got even worse last week. As you mentioned earlier, Louise, almost 13 million people have been affected. Their prescriptions have been hacked. But one thing that we didn't expect was that the company has now pretty much wiped its hands of the whole affair. It's gone into voluntary administration and is now being liquidated. And there's no money for any compensation for the affected people. And it looks like the company's just going to walk away from it, which I think is outrageous. And I think someone needs to be held to account on the MediSecure board. Well, that's another story that keeps on going. So I think that's actually enough news for the time being. We've covered quite a lot.
Some very interesting stories there. I wonder whether Dr. Glaucomflecken had the same trouble as my colleagues in finding a pen to write his scrawled notes.
He had a clipboard. The old-fashioned way.
Whether anyone has any of those anymore around the hospital. Look, the issue around the HIE is really critical. I mean, it's a huge step forward. It's a step forward which many people have been asking for many, many years, and I really do take my hat off. And Peter O'Halloran did a great job explaining how the program works. But again, none of these things are silver bullets. In itself, the HIE won't solve all of healthcare's problems, but it will alleviate the burden step by step and to make it a little bit easier for clinicians to deliver the high-quality care. And also, I think transparency is a key thing, that we'll be able to see things. It's a steep learning curve. I take my hat off to the people who are really working hard to implement these programs in Australia.
The first step is the modernisation of our My Health record that we've been talking about a lot. And one of the big stories that come out of that presentation in Canberra was that the ADHA is going to go to market for assistance in building a FHIR-based system. So it will no longer be just a whole lot of documents that clinicians have to wade through in the My Health record and patients to see their own information. It'll be atomic data one day, one day. And that's the building blocks of this HIE. So it's very interesting times.
I'm certainly looking forward to it personally as well. I had an experience in the last week where my mum has to get surgery, but the prognosis is not good, right? So she's very stressed. And I was like, maybe we should look at a second opinion, because wonders of telehealth, it doesn't have to be somewhere where she lives even. But she said, I've got a link in my email so I can access the MRI scan. I said, what about the X-ray? She's like, I didn't think to ask. So after 3 phone calls to the hospital, getting moved around different departments, I still can't work out how to get access to my mum's X-ray. This is ridiculous. And so she's probably going to have another one for the next consult. So this duplication of effort, and that's a little tiny example and it's hardly mission critical, but that happens so many times every day, such a waste of money and duplication of effort. I look forward to that not being an issue anymore.
There was a mention of a national diagnostic imaging repository. So you're not actually holding all of the images because that would be just impossible, but at least knowing where they are held locally. So that's something in the future as well, so that we just don't run into these sorts of problems.
And the truth is that the way we deliver care now is based on us not having access to that information. We can really restructure the way we can deliver care by knowing we have access. So getting a second opinion really should be a click away. And if it leads to better outcomes, it's great. It's an exciting time. So hopefully it'll all come into place really quickly.
All right. Yes, let's watch this space. Well, thanks for your update today, Kate. It's always great having you on the pod.
Lovely. See you next time.
Well, George, do you think we succeeded in elevating the conversation? I was concerned I didn't want to get too technical today and trying to, make it real and give real examples for health professionals and consumers. But all is so exciting with this health information exchange and modernising our digital health infrastructure.
As we've pointed out, how clinicians use the HIE is the key thing, and how consumers use it, how people who receive healthcare services use the HIE is critical. So I think we've done a pretty good job in introducing the concept to people and really trying to drive that. We only used the Terminator example once during our whole thing, I think. We're definitely improving there. But again, this is really a social change where technology enables us to do things that we couldn't do beforehand. And even though we've seen some of the shortcomings by things like the CrowdStrike incident, we're still going forward. So by PulsePod 100, we'll have a finely tuned world-class healthcare system here in Australia, and we can step back and take credit for part of that journey forward.
All right, predictions. A new segment we can introduce. Nice one, George. Well, always been great joining you in the PulsePod studio, George. If you could read us out, please.
Great having another PulsePod with you, Louise. And thank you for listening to everyone to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Thanks to Nigel Charters, Emily Maher and Kate McDonald for contributing to today's episode. Subscribe, follow and rate Pulse wherever you get your podcasts. You can subscribe to Pulse IT magazine at www.pulseit, or one word, .news. Send your feedback and questions to pulsepod@pulseit.news.